a family physician in Kitchener, Ontario, and I've been practicing family medicine in various clinical settings for the last 17 years. Today, I have, this great opportunity to kind of be a moderator for this really important session, especially for family physicians. Family medicine is regarded as kind of a unification of physical and behavioral model of illness, and sometimes just through the general shortage of mental health professionals or access to psychiatrists, a lot of us end up doing quite a bit of mental health care for our patients. So I'm going to be moderating the session with Dr. Bassam Salim today, and he will be more than happy to answer any questions that arrive or kind of you have during the session. You can post your questions in the Q&A. Just make sure they're not posted in the chat section. They're only posted in the Q&A section. So myself or Dr. Bassam, some can be typed out and some will be answered according to the time period that we have available. And feedback, please, we need your feedback to kind of keep this conference going. It's very important to the speakers and to the organizers. We will send a feedback kind of form after the conference is done. And to remind you, for people who are getting accredited or looking for accreditation, today's sessions are accredited, including the research poster session that we just finished. In order to obtain your hours, please complete the Google form or the survey form that will be sent to you after the conference. And the resources, whatever we discuss, are available at www.muslimmentalhealth.ca, and we'll also send the link in the chat for you. And now a little brief introduction to our today's speaker. Dr. Salim is an adult psychiatrist at Brampton Civic Hospital. He works both as an inpatient psychiatrist and an outpatient psychiatrist, covering the urgent care clinics at Brampton Civic Hospital. He has interests in mood and anxiety disorders and addictions. And thank you very much, Dr. Salim, for coming on today and giving this important presentation.
Assalamu alaikum. Thank you so much. I'm just going to start by sharing my screen. Just give me 1 second. There we go. Should be okay. And I'll just start the actual. Can everyone see? Is it showing up?
Yes, it is.
Okay, perfect. Okay, Assalamu alaikum. Thank you for giving me this opportunity. We're going to be talking about the guidelines give me 1 second, to practice. So we're going to look at pharmacological tools in depression and anxiety. Most of this information that I've got on my slides is purely from the CANMAC guidelines. In Canada, Health Canada takes a long time to approve things. So we tend to focus a lot more on guidelines, and CANMAC is the main guideline that came out in 2016. And that's kind of where we get a lot of our guidelines from for depression. There's also the anxiety guidelines, which came out, I think it was 2014. And so they, some of the stuff that I've taken has been, in terms of first line evidence, things like that. I've taken all that information from the 2014 guidelines for anxiety as well. So hopefully it'll give a little bit of an idea of, where to go, what kind of symptoms to look out for, and maybe what pharmacological treatments can be used. I've touched on some other stuff as well, and other types of treatments. So hopefully I can get through it quickly. So I just want to start by saying I have no disclosures to make. What are the objectives? Hopefully we'll be able to use a little bit of a clinical case in here as well. But we're going to review the depression and anxiety symptoms, which I'm sure everyone is very familiar with. I will skim over that very quickly. Be familiar with different classes of antidepressant therapy. And we'll talk about how to approach specific symptoms in depression and anxiety. And then the big question that I know a lot of people have is around augmentation. What drugs can we use? What pharmacological agents and can potentially be used? And then we'll talk about new approaches to depression, and any questions that anyone has. Hopefully I can answer them at the end. I have got a second clinical case to work through, which I don't know if we'll have time for it. Hopefully we will. I think it's easier to always learn through clinical cases, and it makes me feel like I'm back in school again. So we'll start with depression. So just reviewing very quickly, I'm sure everyone has heard of Siggy caps, but this is the basic symptoms of depression. People forget that depression is not just a sense of feeling sad and feeling down. It's also a number of other symptoms that are involved. So you have to have, based on the DSM-5, you have to have either low mood or low interest, and then any five of the following symptoms. Now, of course, interest is still in Siggy caps, but changes in sleep, feeling of guilt, change in energy, change in concentration, change in appetite, psychomotor retardation or agitation, and then suicidal thoughts, plans, behaviors, anything like that. So 5 of these, and then along with that, one of the symptoms has to be either low mood or low interest. So just one thing I wanted to specifically say beforehand, and there's actually one other thing I want to mention, which I haven't said. Number one, always ask around suicidal thoughts. Don't be afraid of that. There's people who have depression may have experienced these. And so make sure you always ask about that. The other thing is to always screen for any history of manic or hypomanic symptoms or an episode in the past. You just want to make sure you're ruling out anything. And I see a lot of people coming into my practice or coming into the hospital on my inpatient unit, and they've recently been started on an antidepressant. They've had hypomanic type episodes in the past, and sometimes it's a family doctor, sometimes it's a psychiatrist, sometimes it's someone else. Someone has started an antidepressant without realizing there may have been a history prior to that with either mania or hypomania. So please just make sure you rule that out, that it's not a bipolar illness that may be taking place as opposed to a major depressive disorder. And always screen for psychotic symptoms. I get a lot of medical students, and medical students are excellent. But I will say that one of the things I find them missing is that they'll do Siggy caps, they'll ask questions around anxiety, but they'll miss often the psychotic symptoms. And I see this often in medical students. By the end of the rotations, they're generally a lot better. But just at the beginning, sometimes you see them missing it, and it's important to always recognize that might be a case as well. Okay, so we'll talk about the impact of depression very, very quickly. You guys can read this. I don't need to go through everything, but just I thought this was interesting from the Ministry of Health and Long-Term Care that around 1 in 4 Canadians has had a degree of depression serious enough to need treatment at some time in his or her life. So just keep that in mind, that it's a very, very prevalent illness. I won't go through all the other statistics. We want to focus more on the pharmacology. This is just more statistics. I'm happy to make my slides available afterwards for anyone that wants to look at. And just remember that, a lot of major depressive disorders tend to be chronic. So a lot of them last for a long time. And there is a diagnosis of persistent depressive disorder as well in the DSM-5, which can sometimes be attributed to some of these people. The impacts of depression, I'm going to go through it very, very quickly once again. Work obviously affects their social functioning, with loss of interest, withdrawal from society in general. Especially people forget the low self-esteem and the worthlessness and the low levels of confidence that can impact social functioning. Obviously, there's a lot of effect on relationships when people are feeling down. Perinatal depression in both maternal and paternal parents. You have to remember that effective treatment of treating parents can often improve and decrease psychiatric symptoms in children. And then obviously there's a high risk of chronic medical conditions with major depressive disorder. Often people are just poorly adherent to treatment. It tends to be associated with sedentary lifestyle and then the inflammatory dysfunction. So the goals of treatment based on Catman, what they highlighted was that we have to acutely treat the symptoms and focus on remission. So that's the first few weeks to months of treatment. And then we focus on relapse prevention. And that's with, the educating and supporting self-management, teaching people coping skills, rehabilitating them back into society and into their work programs, for example. Sometimes that's, with modified work hours, treating any comorbid conditions, very, very important. And then obviously monitoring for recurrence. So that could be done through screening tools, through asking patients, through seeing people in regular follow-up in the couple of years following their initial bout of depression. All right. So what are the neurotransmitters that are generally targeted by antidepressants? Generally, we've got 3. And I talk to all my patients about this. I always describe this to them to explain to them why we're using antidepressants, why they're effective, and what we're specifically targeting. So serotonin, this is targeted by most antidepressants. This is the most obvious one. There's a lot of theories around serotonin being implicated in depression. This is the one that I tend to talk about the most. And obviously SSRIs, it's in the name. They focus on serotonin. SNRIs focus on both serotonin and noradrenaline. Tricyclic antidepressants have two spectrums. Some of them are more geared towards noradrenergic effect, which is norepinephrine, and the other ones are more on the serotonergic end of the spectrum. So depending on which one you choose, they may have more of a serotonergic effect or more of a noradrenergic effect. Clomipramine is a good example, which is what we use in, specifically indicated for things like OCD. It's very, very highly serotonergic, so it's on one end of the spectrum. And there are obviously other effects that TCAs have as well, which make them very, very good medications, but at the same time, very messy medications with a lot of side effects. Mirtazapine is the other one that also focuses on serotonin and also has some antihistaminergic and effect as well. And there's a couple of other ways that it works. Dopamine is the other one. The only real antidepressant that really, primarily works on dopamine is bupropion, which is an NDRI, we label it as, which means that it works on noradrenaline and dopamine. And it's a reuptake inhibitor for them, so it increases their amounts. We sometimes use bupropion in patients who, maybe someone who I maybe suspect of having an aspect of ADHD, that maybe it's there, but I'm not totally convinced. Sometimes I might, consider bupropion, see if it makes any change, because there's always that chance that dopaminergic effect will be there, and bupropion may function as a very, very weak stimulant. And then lastly, noradrenaline. And so SNRIs obviously work on noradrenaline. It's important to know that generally with things like venlafaxine, duloxetine, a lot of the time you have to go to higher doses where to get that noradrenergic effect. And then tricyclic antidepressants can obviously also have noradrenaline effects. So risk factors for chronicity or recurrent episodes. I'm going to skip over this because I don't know that we'll have enough time. I want to make sure there's lots of time for questions. But of course, just, I want to make it clear that a really severe initial episode generally warrants more, a longer treatment period. So generally we say after people have recovered or, they've gone through remission, we generally say treat for about 6 months. And then you can potentially taper off medication. So 6 months of remission, not 6 months from the initial episode, but 6 months from remission. You can start to taper off if it's been a mild to moderate depressive episode. When you start to have more severe symptoms, long-term treatment is actually indicated, and that could be 2 years or more. It's never really quite clear, but I would recommend erring on the side of caution. And if someone's tolerating a medication, not having side effects, keep on treating the person. That's not because of pill pushers. It's purely because the evidence shows that a lot of people will have relapses. I want to go back to that initial statistic that I said, around 26.5% of people having more chronic episodes, but also recurrence can be high sometimes. So just keep that in mind. And obviously, if you have some of these other risk factors, that can mean more chronicity or recurrent treatments. So let's go through a clinical case. Best way to learn. Nothing beats a clinical case. So this is a fairly classic case that I tend to see in my practice. So you've got a 35-year-old woman, recently separated, 2 children, difficulty at work and balancing duties because of a past 1.5 months of low mood, decreased interest, poor appetite, low energy, describing feelings like I am such a bad mum, also saying I failed as a wife, struggling at work because of low concentration, feeling tired all the time, occasional passive suicidal thoughts, and significant amotivation. Everything else is negative. There's no past psych history, no suicide attempts in the past, no allergies, no medical conditions, not using any substances. One thing there, though, is that there's a family history of depression in the mother. So looking at this case, you can see that, this is a fairly classic patient, someone who's obviously struggling. It's impacting both work and also her ability to manage her duties at home. That might be with regards to being a mother, with regards to being a family member, with regards to doing things with their children, and so has had no medication trials whatsoever, no previous history of depression. So what do? So typically in this case, you're going to start an antidepressant, and the obvious one would be to start something that you're familiar with. For the most part, there isn't that much difference between antidepressants. It's mostly based on tolerability. So, the other thing I want to mention, which I'll get into as well, is that it doesn't just have to be an antidepressant, right? It could be, especially for mild to moderate depression. This seems, kind of on the higher end, given that she's starting to have suicidal thoughts, but you can always consider doing therapy as well. So cognitive behavioral therapy and interpersonal therapy are generally very highly indicated. Maybe she has a job that allows her to have benefits, that gives us certain amounts of benefits for psychotherapy. It may be worth accessing that. So if you know that there's someone who's maybe in a slightly better financial situation, always consider the psychotherapy first. But in terms of pharmacology, we're going to be starting an antidepressant on this person. Oh, there we go. So just very quickly, wanted to go on, wanted to specifically talk about the initial treatment or options other than antidepressants. Very quickly, cognitive behavioral therapy and interpersonal therapy are the two best. Cognitive behavioral therapy is definitely more widely available and can be used both in groups or as individuals. And CBT is better as a group than IBT. And of course, a combination of both cognitive behavioral therapy and antidepressant therapy is going to be the best way of moving forward. So I know many people know GP psychotherapists, or there may be certain therapists that are you may be involved in your practices or involved in part of the your clinic or something. So just use those people. And especially if someone's able to afford it or has benefits, make sure they access that. It's always better to do that individual piece as opposed to, hospitals that offer groups and things like that, but it may not be everyone's cup of tea. Okay, so going on to the CAMAC guidelines, what are the first line medications? And what are the second line? What are the third line? Now, I don't think any of you guys are going to be using third line. I very rarely use MAO inhibitors, the irreversible ones. I really would not necessarily recommend trying those, definitely not as a first line therapy. So we'll ignore the third line for now, and even the second line to a certain extent. I want everyone to focus on the first line and see just how many options there are. These are all first line medications that have level 1 evidence. So any one of these is a reasonable medication. I won't talk out and say every single one of them separately. This stuff is all available online. The CAMAC guidelines are available online for free. But I just wanted to make it clear how many of these there are. And so this is directly from the CAMAC guidelines. You've got pretty much all the SSRIs there. You've got pretty much the other medications that I talked about, bupropion. Agomelatine isn't even available in Canada, but for some reason they love mentioning it. But so we can ignore that one. Milnacipran is also not available here. We have levomilnacipran, which is a second line agent. But venlafaxine, the SNRI, including duloxetine, desvenlafaxine, which is Pristiq. I'm in no way affiliate with any of these drug companies, just making it easy for people to know. But these are all medications that are routinely available. The last one you can see is vortioxetine. Vortioxetine is Trintellix, and I'm sure a lot of you have heard of that. I have been receiving a lot of patients who have already tried vortioxetine, but that's an interesting medication that it's multimodal. So it's a pretty good option. Second line ones, this is where you start to get the TCAs, maybe some kind of left field, other SNRIs. And then meclobamide, which is a reversible MAO inhibitor. Quetiapine, interesting to say, interesting with this one because we often tend to add it onto things. I just want to make it clear that there is second line evidence to show that quetiapine can be used as a monotherapy, not just as an adjunctive therapy. So these are all the ones that we could try. So we could try any one of these for the clinical case that we described above, right? Yes, it says that she has fatigue. Yes, it says that she has low energy. Maybe some trouble with her appetite. That doesn't mean that you have to go to a specific medication that improves those factors. Often, part of the actual depressive syndrome is having all those symptoms. So poor sleep and low energy, poor concentration, and maybe affecting the cognitive domain. Those are normal symptoms of depression. We expect to see those. That doesn't mean that if someone has poor sleep as part of their depression, you have to use mirtazapine as a first line medication. But if sleep is the one thing that is specifically affecting them more than anything else, you may think about potentially starting mirtazapine. In this case, it was a pretty classic case of depression that I think it's reasonable to go for a traditional medication like an SSRI first, and then work from there. Theoretically speaking, those symptoms should all improve because you're treating depression, and once you're treating depression, you should be affecting all of the symptoms of depression. So which antidepressant should I use? We've kind of talked about that a little bit, but obviously looking at the two most important things, which are both patient factors and medication factors. So the patient factors, first of all, do they have a preference? Have they said to you, doc, you offered me, an SSRI, an SNRI, and bupropion. I prefer bupropion for whatever reason. They, it may have been something that you said that made them feel that would be a better option. You're obviously not going to offer a medication that you don't think is going to be effective. And so, sometimes, listen to what they want is important. Family members with a similar comorbidity and with a proven on a specific medication, it makes sense. I have a patient just the other day who, well, it's been a few weeks that I've seen her, but she's improved significantly with venlafaxine, which another two family members are on. So there are genetics that play a role in these things. And I think it's important to know that, if someone's mum has improved with a specific medication, why not try that? In this case that I just gave, a clinical case, the patient's mum has or mother has suffered with a similar depressive illness, and so it may be worth asking the mother, well, hey, which medication are you on? If she's not already aware, maybe there's going to be some effect. And then obviously clinical features. Understanding the mechanism of action of an antidepressant can be helpful in targeting specific symptoms. So if you know that something is really highly noradrenergic, especially at higher doses, it gives you an idea of what you need to do. There's no point taking venlafaxine and starting it at 37.5 milligrams and then never increasing it up to a dose above 150, 225, where it starts to have more of a noradrenergic effect. And so just think about the mechanism of action and what neurotransmitters that medication might act on, and sometimes that can help you to decide which antidepressant you should be using. Obviously, medication factors are really important. So tolerability. If someone has really struggled with one SSRI, they may not be open to trying another SSRI. They may want an SNRI or something different because they've had bad side effects with one. So take that into account, and obviously, know what previous trials have been done. Cost is a big thing, right? Some medications are really expensive. People don't have coverage. They don't have anything. Maybe they work for themselves and they don't want to have to pay so much money for something. Just keep that in mind too. For the most part, most antidepressants are on the ODB here in Ontario. And I recognize there might be people from other provinces, but I'm not entirely sure about those. I know things like vortioxetine, for example, are now available on ODB, whereas previously you used to pay for them. So just keep that in mind as well. And I know many of you do, but just important to keep in mind. Specific clinical dimensions that may influence a specific antidepressant. Cognitive dysfunction. So vortioxetine has effect on 5-HT7, which is one of the serotonin receptors. And that's kind of their argument for saying why it's specifically helpful with cognitive dysfunction. So it's supposed to limit the side effects and help. So if you have someone who's really struggling with memory and says to you, hey, doc, memory is the biggest concern. I just can't remember anything. I just can't concentrate on anything. You may be leaning towards potentially choosing something like vortioxetine. Otherwise, level 2 evidence would be propion and duloxetine and all SSRIs. So you wouldn't really go wrong with taking any medication. And I would take this whole cognitive dysfunction piece just a little bit with a grain of salt. Vortioxetine is a multimodal antidepressant, but at the same time, there may be other antidepressants that also have the same effect. It just hasn't been specifically studied. So just keep that in mind as well. Sleep disturbances. Agomelatine we don't really have here, but it seems to keep coming up. But that has level 1 evidence. Otherwise, mirtazapine has excellent evidence. It has antihistaminergic effects, which definitely can promote sleep, but also promote appetite. And that even tends to be the case at lower doses. So even 7.5 milligrams and 15 milligrams of mirtazapine will have those effects. By increasing the dose of mirtazapine, you won't necessarily get more of a sleep effect. Quetiapine. This could be added as an adjunct, or it could be used as a monotherapy, like we said before. I wouldn't recommend trying quetiapine as a monotherapy until you've already tried other SSRIs. And then trazodone is a great adjunct to add on. What I will say is this is one of the medications that can, number one, lower blood pressure in the morning, but also is one of those medications where there's, this fine print of potentially causing priapism. Just make sure you counsel male patients on that. I haven't seen it yet, but I wouldn't want to have not counseled someone and then find out that it happens. So just another thing to focus on. And then obviously somatic symptoms. Duloxetine, very, very highly indicated. A lot of you guys who do pain clinics or regularly prescribe, see people with pain disorders, things like that. Duloxetine can help. And that's partly down to the noradrenergic effect of it. And we typically don't use it beyond 60 to 90 milligrams for depression because there's not really much evidence. But for pain disorders, it's definitely indicated up to 120 milligrams. And then bupropion for fatigue. So people who are feeling low in energy, if you're suddenly giving them medication that boosts noradrenaline and also boosts dopamine, bupropion, it makes sense that it would help. But you can see the second level 2 evidence shows very, very clearly that traditional SSRIs and SNRIs are also helpful with all these things. I'm going to skip over this slide. This is something that you guys can look at afterwards if you want. It just there are specifiers within the DSM-5 with regards to depression. So you could have major depressive disorder with anxious distress. It just talks about maybe some of the other medications that you might consider, or some of the specific medications you would consider if you are experiencing one of those specifiers as well. So with psychotic features, I think it's very, very obvious, you use an antipsychotic along with the antidepressant. All right. So this question around, are antidepressants effective? I'm biased, but I would say yes, but also evidence states yes. So if you look at some of the older trials and everything, they're in head-to-head kind of studies. Escitalopram, mirtazapine, sertraline, and venlafaxine show a superior level of evidence. That's based on multiple meta-analyses. They're also, very highly studied medications. There was a Cipriani study in 2018 that came out, which was after the CANMAC guidelines, which did show that antidepressants are effective as compared to a placebo. And I've posted, that study was only done up to 8 weeks though. So just keep that in mind as well. I will show you some of the tables. I'm sorry, I know it's small, but you can see over there that if you look at the table A, you can see that all of them are favoring the active drug, and that most of them seem to be effective with decent odds ratios. If you look at the second table, you can see that the only one with an unacceptable kind of acceptability or tolerability was clomipramine, and that has the highest dropouts. That being said, we still use clomipramine a lot. I use it for a lot of OCD patients who have trialed other medications and haven't benefited, and they do generally do quite well. Sexual side effects. This is always one which is talked about, especially with I know a lot of the family doctors over here will be asked about this. And if I had to say one of the things that causes people to stop taking antidepressants much of the time, certainly sexual side effects can be the one. However, they're very inconsistently and inadequately reported. We do we definitely do have sexual side effects on antidepressants. We see that a lot in our practice. There is some studies that show that bupropion, mirtazapine, vilazodone, and vortioxetine do help. Once again, agomelatine is mentioned, but we don't necessarily have that here. I will say that adding on bupropion as an adjunct can sometimes even decrease sexual side effects. So if you're going to go for one that specifically, does decrease or at least doesn't cause sexual side effects, these would be the ones to go for. So bupropion, mirtazapine, vilazodone, and vortioxetine. Please keep in mind, vilazodone is not first line, doesn't have level 1 evidence. It's maintained as a second line therapy. So on a personal level, bupropion, mirtazapine, and vortioxetine would obviously be the ones that I go for, bearing in mind other symptoms and comorbidities as well. If someone has anxiety, I don't necessarily jump for something like bupropion, which causes high dopamine and noradrenaline levels. Okay, we should just talk about the suicide risk. I know many people are concerned about this, and I understand there might be people who are not family doctors also in the audience. So I want to make it clear that antidepressants, yes, there is a black box warning. That being said, there are plenty of studies that show an improvement in suicidal thoughts with the use of antidepressants. So in children and adolescents, yes, there is that black box warning. But they have done they have looked at the data, and they noticed that because of these studies, there were concerns, and people actually stopped giving antidepressants to young people, and the suicide rate has gone up in children and adolescents. So I think that kind of proves that antidepressants are helpful. And there are a number of theories that I'm not going to go into necessarily right now. What I would say is avoid an SNRI. There are higher rates of withdrawal with things like venlafaxine and duloxetine. So while they're not addictive, these medications, there certainly can be a sense of physical withdrawal that comes, and sometimes that agitation can push people to maybe go through. But it's not necessarily increased suicidality, it's more of an increase in suicidal thoughts. Uncommon but serious adverse effects of antidepressants. So I would say one of the big ones with this is QTC prolongation, which can lead to torsades. That is, I've never seen it necessarily. I've never seen someone actually get to a point where they had torsades, but I certainly do see QTC prolongation. So citalopram, escitalopram, certainly, especially over the age of 65, we recommend only going to 10 milligrams for escitalopram and to 20 milligrams for citalopram. So you would go to half the dose, and you wouldn't go above that unless you have an ECG on file and you've been cleared. So I would recommend staying below the staying at the half doses for them if you're treating an over 65 age patient. You don't have to get an ECG on every single person, but if you know that there's someone who's at risk who's also taking quetiapine and also is on, methadone therapy and is taking other agents that can also prolong the QTC, I would certainly look at it, and I would consider maybe not using citalopram or escitalopram in that patient. It's a very low risk at therapeutic doses. This is something that we screen for and put people on telemetry if they overdose. So if we see an overdose on an SSRI, often we'll then start to think about it. If we see an overdose on quetiapine, we'll think about it. I want to talk about the hyponatremia. This is, I don't know if there's any internists, but it's not always the SSRI causing the hyponatremia. There are other causes for hyponatremia other than SSRIs. I used to work on CL, especially when I was finishing up residency, and it's one of my interests. I still do cover CL shifts every now and then. And a lot of the time I'll get, a consult for, is this the SSRI? And all the medications will have been stopped. And this is someone who's been on an SSRI for 3 years. There are other drugs that also cause hyponatremia. It doesn't have to be the SSRI. Risk of GI bleeding, it's very, very low. I wouldn't necessarily stop an SSRI for surgery, but you can certainly discuss that with the surgeon and think about, maybe referring to psychiatry if that's a concern. It happens because of a de-inhibition of platelet aggregation, which is a serotonergic effect. And then we won't talk about any others. So let's return to the clinical case. So our patient, which we started on a traditional antidepressant, which was an SSRI, has noticed a mild improvement after 4 weeks, and she's now on 100 milligrams daily of sertraline. Energy and mood have somewhat improved, and she hasn't had any suicidal thoughts now for 2.5 weeks. This is positive. She's had improvement in the first 2 to 4 weeks. And based on that, we do have certain algorithms. I would say that at this point, she's on a therapeutic dose, 100 milligrams daily, but it's not quite as therapeutic as it could be. She's still having some symptoms, but has noticed some improvement. So the next step would be, in my opinion, at this point, I would increase the medication. I would say, okay, let's go up a little bit higher and see if that makes any difference. All right. So when to decide when to switch or augment? If there's an early response within 2 to 4 weeks, like we just said, and we noticed with this case, this is an indicator to increase the dose and to continue with the same therapy. No point in changing. If someone's tolerating a medication, number one, if they're responding early to the medication and they don't have any concerns around taking the medication on an ongoing basis, it makes sense to continue with that same therapy that you're already on. There's no point changing at that point. Yes, she hasn't fully improved, but she has shown some improvement and some overall effect has been attributed to the medication. It makes sense to continue. So a complete trial, we often say that, 4 to 6 weeks for a full antidepressant trial. She's not even at that point yet. I would continue with the medication and give it a bit of a longer trial. And the thing that people forget is that has to be an adequate trial at a therapeutic dose. So 100 milligrams of sertraline is a therapeutic dose. 25 milligrams is not a therapeutic dose. I see patients all the time who have tried, 3 different antidepressants. I asked the patient what doses they went to, and I find out they went to 25 milligrams of sertraline, didn't find it helpful, so stopped after 3 weeks. Then they tried escitalopram, but only took 5 milligrams of that. And then they tried another medication, and that was also under titrated, if that's a word. So I would say that please give people complete trials of medications, 6 to 12 weeks at a therapeutic dose generally. If there's no treatment or there's a partial response, but the patient's tolerating it, switch to a higher dose and optimize the treatment before considering adding on an adjunct or switching to another medication. Now, if in 3 months she comes back and she says, hey, listen, I feel no different, I'm still the exact same way, I'm still having suicidal thoughts every now and then, I'm still struggling, then you might consider changing. And that's something that we'll talk about in just a second as well. The other thing is that you'll be surprised how many patients believe that you can use this as a PRN. Antidepressants are not PRN medications. They are daily medications to be taken appropriately the way that it's instructed on the label and the way that we prescribe them. So just take into account that there may be a non-adherence or inappropriate use. Please counsel patients on this. It's very, very important to tell them it's going to take 4 to 6 weeks. Tell them you need to get the therapeutic dose and tell them they need to give the medication time. I know it's hard, but people don't improve quickly from depression. If someone's been struggling with depression for a whole year, it's not going to just go away just like that. So give it some time. So this is specifically from CANMAC guidelines. I wish it was more colorful. Unfortunately, this one's not, but this is the algorithm that we generally use. And early improvement is considered 2 to 4 weeks. If there's no early improvement, then you might consider a switch or adjunct, but you need to consider factors for that specifically. Yes, you could switch to another, depending on how many times you've been through the cycle, you may choose to start going to second line therapies or, to try and treat appropriately. But I think it's fair game to try at least 2 or 3 first line therapies before considering another adjunct. And at that point, it would be totally reasonable to refer to psychiatry anyway, even potentially before that. That's all totally reasonable. I'll let you guys look at this at another point. So the patient, let's go back to the clinical case. So the patient's now 12 weeks into the trial and has noticed further improvement, but still struggles with low mood and low self-esteem at times. Her energy has not completely improved, and now she's on 200 milligrams of sertraline daily. She continues to struggle with amotivation, and she's been on this dose now for about 3 weeks at 200 milligrams. So this sounds like a fairly reasonable trial. This is someone who's improving. They're doing better, but at the same time, they still have some lingering symptoms. And sometimes mood improves before the physical symptoms. Sometimes the physical symptoms start to improve before the mood does. So this is someone who's still struggling with low self-esteem. Now, she has a very difficult circumstance. You know what I mean? She's just separated. She has children. There's probably some guilt around her not being the best mother that she could be. Certainly some low self-esteem. And so, naturally, that'll take some time to go away with the circumstances. But what are the next steps now? Well, she's struggling with amotivation, with energy. I think this would be a reasonable point at which you might consider augmenting. She's benefited from a medication. She's doing well on that medication. She's tolerating the medication, but it can't really be titrated any further. I mean, it can, but I don't expect everyone here to be comfortable going to 400 milligrams of sertraline, and there's no real indication for that for just depression. So we might consider at this point augmenting. Okay. So these are the recommendations for adjunctive medication. Now, I know a lot of you already use these and are very routinely augmenting. Certainly aripiprazole is used for augmentation. Certainly quetiapine, we often add it on for sleep. One thing I want to just, ask everyone to pay attention to is the dosing. So aripiprazole has level 1 evidence, but not to be dosed till 30 milligrams. That's more of an antipsychotic dose at that point. Or maybe even a mood stabilizing dose. Aripiprazole is recommended between 2 to 15 milligrams. And I would argue that even up to 10 milligrams, after 10 milligrams, you're not going to see too much change. But it's a reasonable first line augmentation strategy. Quetiapine would be another one. Certainly between 150 to 300 milligrams is more of an antidepressant dose. And then risperidone, anywhere between 1 to 3 milligrams is a reasonable augmentation as well. I want to make it clear that brexpiprazole, because it's a bit newer, does have level 1 evidence, but it's still second line. That being said, I have seen a lot of my family physician colleagues using this very appropriately. I think brexpiprazole is actually on ODB as well now, so you can, it's not, it is covered for some extra people as well. So just keeping that in mind. The other one I just want to quickly point to is olanzapine. That has level 1 evidence, but it's second line. That's mostly based on side effects. Olanzapine certainly causes weight gain, sedation, and that can lead to other complications, especially metabolic side effects. So that's probably why it's a lower level, a second line, but it does have level 1 evidence. Lastly, I'm going to talk about this right at the end, but ketamine is experimental at the moment, but it does have level 1 evidence. And so you might be hearing more about that in the future. But I'm not going to get into that right now. Okay, so when do you consider a switch? Is this their first trial on an antidepressant? Are they not tolerating it? Is there a lack of response? Did you need more time to wait for a response? And then obviously if the patient prefers to switch. So if the patient's saying, hey, listen, I don't like this one, it makes me feel a bit odd, I can't really put my finger on it, but it's not quite making me feel good. Or, let's say they've been on it now for 6 weeks and there's been no change whatsoever and it's been an appropriate dosage, I might consider a switch. When do you consider adjuncting or augmentation with something else? If you've already trialed 2 antidepressants and haven't had any major improvement with either of them, if let's say you have a well-tolerated antidepressant but haven't experienced any side effects, you might say, okay, well, it's being tolerated at least. Let's consider adjuncting something else. If there's a partial response to the initial antidepressant, then you could do it. Specific residual symptoms or side effects. they can obviously be targeted as well. And so you might have someone like our case, for example, where the lady is still struggling with low energy. You may consider something like Abilify, which can be activating. It's one of the antipsychotics that we give in the morning. So we may choose to adjunct with that. Let's say you're having someone who's still struggling to sleep, and they've benefited, their mood's better, but they're still saying they're struggling sleeping. You may want to add on quetiapine. You may even consider mirtazapine, which is second line, if the person's not really too keen on quetiapine, or if there's some other issue with quetiapine. And so, obviously you ask the patient, you say, hey, listen, you've tried one antidepressant now. What do you think? Do you think it's working at all? Do you want to consider coming off this one and maybe switching to a different one? All both reasonable options. It's really just a case of what the patient prefers at that point. Some people will say, hey, doc, I don't want to be on two antidepressants. I don't want to be on two medications. I hate medications. I'm barely even agreeing to this one. So you may have a harder time convincing them that you want to adjunct with another therapy to help with a side effect or with ongoing treatment. Just to clear up some misconceptions, I have been asked about this by different people. Generally, it's less so by family doctors and more so by average people who patients that want to know things. Antidepressants are not addictive. Sometimes there can be an aspect of physical withdrawal that you can experience. However, that's generally very short-lived and is more known as a withdrawal syndrome, and that's a physical dependence that comes from the medication. We see this a lot with SNRIs. They don't necessarily change your brain chemicals completely. It's more the case of they're acting on receptors that will affect that will change the effect of a neurotransmitter. So it's not a case of where you're completely changing your brain chemical composition. These are chemicals that are already in your brain, and it's about how much effect they're having or how long they stay effective for. They typically don't cause weight gain apart from mirtazapine. But it's always possible. These are things which are fine print. Most people don't necessarily struggle with weight gain or weight loss. Certainly, it could improve your appetite if that's something you're struggling with, or it could, make you nauseous, which may and give you abdominal discomfort, which may affect your weight. But it's not typically that associated with antidepressants. They don't change personality. Now, that being said, I have to be very honest. With SSRIs, I do hear people complaining of emotional blunting at times. Not everyone, but occasionally, I do hear people complaining of emotional blunting. It's not an unheard of complaint that people have with antidepressants. So just keep that in mind too. And then I won't go into the drug-drug interactions, but fluvoxamine is a pretty dirty drug. Just keep that in mind. So what are the other approaches to depression? There's neurostimulation. And there's ketamine. Neurostimulation, very quickly, ECT is definitely an amazing treatment, regardless of how it's been sold in media and in Hollywood. It is not this barbaric treatment that we're putting on people. It's simply just impractical to do for every single person. But it definitely is one of the best treatments we have for depression. It works very, very well. I've seen people change completely. People that I've struggled with in terms of their treatment on medications, and once they've done ECT, things have become significantly better in terms of their lives, and they've returned back to a normal functional level. I have multiple examples, and the response rates are very good. I won't get into specific statistics, but very, very good treatment. RTMS definitely is first line in terms of neurostimulation. Most of the time, people need to have at least tried one antidepressant beforehand, and that antidepressant needs to have failed them at least once before we can consider something like RTMS. There are a few places doing it. Certainly at Brampton Civic Hospital, where I work, we have 2 RTMS machines, and we are doing it. But it's basically you're taking taking these magnetic field pulses, which are hopefully affecting some of the specific receptors in the brain involved with mood. There's a 58% response and 37% remission. Different places will do different numbers of treatments. So sometimes you can do 5 times a week. I think that's more common, and 3 times a week treatments are also possible. There are some places, I think maybe UHN was doing this as experimentally at one point, considering multiple daily treatments. They have the most RTMS machines, but there are different places doing different things with RTMS. Ketamine, I kind of already talked about it, and I want to make sure there's time for questions. So I want to actually finish up. I was going to talk about anxiety, and I guess I want to just quickly highlight with anxiety, generalized anxiety disorder is probably the most common one that we see on a regular basis that continues to affect people, especially with with adults, often comorbid with depression. Remember that. It's not just a case of people saying they feel anxious, right? It's feeling on edge, fatigued, worrying excessively, overthinking things constantly to the point where they can't sleep. Complaining of muscle soreness and feeling really, really tense. It affects their concentration. It makes them very, very irritable. This is something that tends to wax and wane throughout life, and can, at times be a lot worse and at times be better. And especially with mood disorders, we tend to see it come about and get worse. Just prevalence of different anxiety disorders. I think we'll skip over this bit. Don't need to talk about the diagnosis necessarily. But first-line treatment, I just wanted to highlight this. SSRIs, escitalopram, paroxetine, sertraline, based on anxiety guidelines. SNRIs, venlafaxine, duloxetine, are both reasonable. The one that I specifically wanted to bring your attention to was pregabalin. So pregabalin, which is Lyrica, like I said, I'm not affiliated by any means with any drug companies, but pregabalin is quite effective at treating anxiety and can often be adjuncted on with an antidepressant as well. So it's first line both as a monotherapy for anxiety, but also as an adjunctive medication, and that's for both generalized anxiety and social anxiety disorder, which make up the predominant types of anxiety for the most part. And I think I'm essentially just saying the exact same thing here, but yeah, atypical antipsychotics, once again, used for adjunction. And then I just wanted to quickly talk about benzodiazepines. I see a lot of patients coming in with benzos, not blaming anyone, not saying it's really bad practice, but generally benzodiazepines like lorazepam are considered a temporary therapy. So I might start using this for someone who's really highly anxious and struggles with panic attacks. I may add on lorazepam as a brief therapy until an antidepressant has been going for a little while and a complete trial is done and the patient's on a therapeutic dose. So avoid the long-term use. As people get older, there are lots and lots of side effects, not to mention, of course, the risk of dependence. A few clinical pearls. I think I mentioned most of these already. Try to optimize one medication before switching or adding another. For comorbid anxiety and depression, try to use a medication which is listed on both guidelines. Generally, that's SSRIs, SNRIs, and then pregabalin for anxiety can be used as an adjunct as well. Make sure you give a fair trial on an antidepressant at a therapeutic dose, not at 25 milligrams of sertraline for the last 2 months. Consider an adjunctive medication when there is some response. The main reason to switch the antidepressants are lack of response or side effects or intolerability, and always consider a family history. It's important. It works. I've seen it work. Anecdotal, but it does help sometimes. And don't be afraid to refer to psychiatry. By no means is this a presentation to say, you guys should be doing all of this by yourselves and psychiatry shouldn't have to be involved and make less work for us. By no means am I saying that. Refer to psychiatry if you need to. All right, I'm just wondering from the moderator, should we go into questions or should I work through a clinical case?
We do have one question for now. Depends on kind of how long the second case is. If you want to maybe take a brief pause to answer this question, just give me a second.
So should I read out the question then?
Just give me a second. I am going to. The question is, are there any clinical tests a patient can take to test levels of neurotransmitters? Is there any test to determine serotonin production?
I have to say I'm not too sure. There certainly were genetic studies that were done before. There was the impact study at CAMH that was done a little while ago. I don't know if the impact study is still going on, but you certainly could have genetics tested over there, and it would give you a breakdown similar to when we check sensitivity for antibiotics. It would give a breakdown of medications that would be I guess it's based on metabolism and things like that as well. So it would certainly give it would give a breakdown of which antidepressants based on your genetics would be helpful for you. I don't know that there's a way of testing serotonin levels. And things like that, and there is an aspect of the CANMAC guidelines which talks about natural supplements that you could potentially take. I'm happy to share those afterwards if you want. I don't want to go through all of them right now, but certainly with regards to boosting serotonin, there are certain supplements that you can take that would help with that. So tryptophan tends to be one of them. I have a couple of patients on tryptophan right now, and there are a couple of other supplements that you could potentially use to boost that. But I don't know if there's any way of specifically checking how much your kind of serotonin levels are.
Yeah, okay. Thank you very much for the answer. That's kind of what I thought as well. So just another question regarding what you just said about supplementation. So these supplementations would be added on top to the therapeutic management that you're already providing to the patient, right?
Yeah.
The medications.
Exactly. But I would be very careful. So there are some which can have adverse effects. Certainly St. John's wort. You need to, you need to tell your patients to let you know if they are using any kind of supplement. It's very, very important, because sometimes people take supplements without realizing. I know that's kind of the classic example, but that can have interactions or, increased risk of things like serotonin syndrome, things like that. So it's rare. I wouldn't expect it, but just in case, you need to make sure that you're aware.
Sure. We still have 10 minutes. I saw another question that was answered by Dr. Malik. So we don't have any questions currently. If you want, you can continue with the presentation.
Okay. Maybe we'll just go on to this clinical case. Sometimes it's just nice to see that. I just need to work out how to get rid of the actual Q&A box. How do I get rid of it?
There must be a small.
Oh, there it is. Okay. All right. So clinical case 2. This is more just I'm happy for people to type answers, or I don't know, are people allowed to unmute themselves and shout out an answer? However people want, I don't mind working through the case with people. So let's say you have the second case. Sorry. Let me go back. So a 63-year-old man, married, has long-standing previous history of generalized anxiety disorder, has been using occasional lorazepam for many years because of anxiety and difficulty with sleep. Not abusing the benzodiazepines, but certainly does use them. Over the last 3 to 4 months, he has been feeling increasingly anxious to the point where he is overthinking excessively and checks on his children multiple times a day to ensure they are doing well. Additionally, he now meets criteria for depression and has passive thoughts of wanting to be dead, as this would be easier than living the way that he's living. There's no substance use on board. He is only able to enjoy his grandchildren, but otherwise does not have much joy, feels very guilty about this, has low energy and difficulty with sleep because of overthinking, and struggles with concentration and memory. He was recently diagnosed with atrial fibrillation and has a history of hypertension. What are people's thoughts? Or I can just work through this as well if people would prefer. I don't know if anyone wants to answer. Oh, whoops. May have given away a potential answer. Okay, so this is an interesting case, right? You've got someone who has a long-standing history of anxiety, which I was saying often waxes and wanes. There are likely periods, and this is a very, very common case that we see, right? There are likely periods where this person is probably supplementing with lorazepam at times because of concerns around the anxiety and not really having anything else on board, right? Doesn't sound like he's on any other medications at the moment. Struggles with the overthinking and that feeling of, tension, probably muscle tension, feeling on edge, keyed up at times. And so probably he's using lorazepam on a day that he's feeling very, very highly anxious. We see this all the time. Now we're starting to see that he's meeting criteria for depression. I haven't put specific SIGI-CAP symptoms that he's having, but I do think that I just written that he meets criteria for depression to make it less writing on the page and less wordy. But there's also this couple of medical issues that are going on, right? He's 63. He now has atrial fibrillation, and there's a history of hypertension. So there are certain medications that you may consider, may not consider. Let me just see what I put with this. So traditionally, you would still want to go for an SSRI. They tend to be safe. They tend to not have too many side effects or anything like that he would have trouble with. He has atrial fibrillation, and that might be a factor. It's not QTC prolongation, but certainly is an ECG change, so it may limit what you want to do. And there's hypertension. So let's see what we put. And I think I've made this case specifically to maybe. Okay. So we said that he started on escitalopram. Now, typically, I probably wouldn't actually start someone on escitalopram because of the atrial fibrillation. Like I said, it's not QTC prolongation, but I think it just makes us feel a little bit uneasy when there's already something to do with the heart already going on. But in this case, he started on escitalopram, comes back 1.5 weeks later because of severe nausea and abdominal discomfort. He doesn't want to take it any longer. What would you consider then? Right now, he's having a clear side effect on the medication. So based on the algorithm that we were kind of talking about, it's only been 1.5 weeks, not even 2 weeks at this point. And he's saying that he can't tolerate it. He doesn't want to take the medication any longer. We cannot force these medications on anyone. There are certainly situations where we do force people within kind of the hospital setting. But in this case, we can't force antidepressants on anyone, right? So now he doesn't want to take it any longer. He's got side effects. Very reasonable for him to consider, say, I don't want to be on this. So we switch, right? We go to a different antidepressant. We say, okay, well, it didn't work out with the escitalopram. Kind of made us feel uneasy anyway because of the atrial fibrillation. Why don't we try something else? So we change the medication to another SSRI. And now he comes back and he says that he's not feeling any different after 6 weeks. The dose has been at a maximum therapeutic dose for 2 weeks. He's tolerating the medication well, but he hasn't really felt any different. So you tell him, give the medication some more time, and now he comes back to you again. This time, he's been on the therapeutic dose for 6 weeks, and he returns to your clinic at this point stating that there's, again, no change in symptoms. Anxiety is still very difficult to control. So what do you do now? I think I did finish this case. I was thinking we could work through it together, like a workshop, but I guess maybe difficult in this situation. Okay. So you switch antidepressants another time because there hasn't been, with the first one he didn't tolerate, so it wasn't really a trial. The second time he tolerated but had no previous kind of response. Now you try 2 separate SSRI medications. So at this point, right, you wanna switch to a different kind of antidepressant. So this is the point at which you might be considering, okay, maybe I should do an SNRI, maybe I should try mirtazapine, maybe I should try vortioxetine, even though those don't have, technically they're not really first line for the anxiety guidelines. You might be wanting to change class at this point. I think it's totally reasonable to give someone 2 trials on an SSRI medication and then say, okay, you know what, these are not working. Those are the ones we know the most about, right? So there's nothing wrong with trying those. You might want to switch to an SNRI now. So you switch into an SNRI or some other class of medication at this point. He tolerates this new antidepressant well and notes moderate improvement over 8 weeks in his depression and anxiety. Unfortunately, still struggling with difficulty sleeping and overthinking at night. All right. This is a very, very kind of classic case. And this is exactly, situations that I come across all the time in my outpatient clinic. So now he's struggling with specific things. He's telling you, hey, listen, doc, I'm feeling a bit better. I'm still a bit anxious at times, but I've noticed some improvement. I'm definitely overthinking less during the day. I'm not calling my kids multiple times. My energy is a bit better, but I'm still struggling with sleep. I can't seem to shake that overthinking at night. I'm still struggling with that. So what do you do at this point? This is where you might want to adjunct, right? You might want to say, okay, well, you're already on, let's say you switch to venlafaxine. Why don't we put you on something else? So at this point, it's like, do we augment a switch? Well, I would probably augment at that point, right? Quetiapine's an option, mirtazapine's an option. I'm sorry, the case was supposed to be worked through, I guess, but that hasn't been possible in the same way. But this is the typical kind of example that we see, and over the period of 3 months, we might have these changes. So I'll open it up. That's all I had to say.
I do have a question in the chat box here. Now, Shaista asked if you could use ECT. If we can just kind of answer that briefly. Okay.
Could you use ECT for this patient? I would say that if you look at this question realistically in this clinical scenario, this is someone who hasn't been on any medications in the past, right? You try one medication, which was escitalopram, maybe not the best choice, but you tried escitalopram. It didn't necessarily work, but mainly because it wasn't tolerated. That's not a trial. For ECT, you typically need at least 2 antidepressant trials, and I would go a little bit longer. It is impractical, right? This is someone who is 63 years old, not old by any means by today's standards, but at the same time is someone who is who likely has responsibilities, may still be working. We haven't necessarily said that. It's not easy to go to a hospital, right? First of all, you have to find a hospital, right? ECT has shut down a lot over the last little while. So this is just real life example, but ECT isn't as readily available as much as it was before. Like, for example, my hospital, we're only doing it 2 times a week now. And that's mostly, for people who are inpatients that are very, very severe. In this case, he's not by any means severe enough to warrant ECT yet. Now, if it was possible and very readily available, would ECT be a good option? Yeah, absolutely. Right. But typically we use ECT more for treatment-resistant depression. There are specific indications for ECT that where it would be first line. But for the most part, I would continue with medications in this patient for now before considering ECT.
Thank you very much, Dr. Salim. It was really good session, good refresher. And kind of you touched on the new stuff as well. I know we were getting all these advertisements and stuff from the ketamine clinic, all of a sudden, all these new ketamine clinics running. If people have any other questions, if that's okay with you, they can post in the Q&A box. If you wouldn't mind staying for a little short period, a few minutes after the presentation.
And I do want to say, can I just say thank you to all my family physician colleagues? I know that you guys are, it's more master of all trades as opposed to jack of all trades nowadays. There's a lot more pressure, and I know with hospitals often making it impossible for referrals, and saying we'll only see a patient once, we're not going to see them any more than that. I understand it's very, very tough, and mental health is suffering a lot, especially after the pandemic and changes going on in the world. So I do want to say a big thank you. I have noticed that a lot of the people I'm seeing are already on very appropriate medications. They're already being augmented. I see newer medications being used, which I find very positive. I am seeing a lot of, you guys are going above and beyond what you guys should be having to do. And so a lot of respect there. I know it's tough. We will try our best to try and shorten.
You guys are trying really hard as well. I know the e-consults have made things kind of, a lot easier, and a lot of we can get some help, through e-consults. So I guess it's always kind of that collaborative approach to a patient that actually helps them. At the end of the day, our goal is, just the improvement in the patient, not for ourselves. So thank you very much for your time. Thank you very much for this amazing presentation. You summarized a lot of things in that 55-minute time that we gave you. But we'll be taking a short break to pray Zohar for those in the Eastern time zone now. And during this break, we'll be sharing some resources with you about mental health services in the community. And we'll be also playing the resource list, and the FAIR video during break. So don't worry if you missed part of it after the break. Inshallah, next session B will be on suicide and self-harm, evidence-based safety assessments and tools. Thank you very much again, Dr. Salim. And hopefully we'll see you next year with another topic.
Inshallah. Thank you so much.
No problem. Assalamu alaikum.